A 42-year-old patient presents with progressive exertional dyspnea lasting for 6 months. Her chest HRCT demonstrates ground glass opacities and parenchymal bands predominantly at the lung bases, with relative subpleural sparing, highly typical of an NSIP pattern. The reading radiologist immediately signed off idiopathic nonspecific interstitial pneumonia without realizing that 2 weeks later, the patient presented with acute respiratory failure.
Exactly. The critical finding that was missed was the dry, cracked skin along the radial borders of her fingers, classic mechanic's hands, along with a positive anti-Jo1 antibody test. If we had routinely checked for extrapulmonary clinical signs and ordered an autoimmune serology panel from the start, this patient would never have been misdiagnosed with idiopathic interstitial pneumonia.
A truly classic clinical diagnostic trap. Welcome back, dear colleagues and doctors, to VietRad Podcast, the premier medical audio network for diagnostic imaging. Today, together with Associate Professor Trường Giang, we are diving deep into the thoracic HRCT spectrum of autoimmune myositis, Sjögren syndrome, and clarifying the true nature of the IPAF multidisciplinary framework.
Thank you, Khánh Linh, and greetings to our listening clinicians. Connective tissue disease-associated interstitial lung disease represents a huge diagnostic challenge due to complex overlapping HRCT manifestations.
Dr. Giang, for autoimmune inflammatory myopathies such as polymyositis, dermatomyositis, and antisynthetase syndrome, what key HRCT features serve as early red flags for radiologists?
In antisynthetase syndrome, interstitial lung disease is present in 70% to 80% of patients carrying anti-J1 antibodies. The most characteristic hallmark on HRCT is the combination of NSIP and OP patterns, creating an NSIP-OP overlap pattern.
How does this NSIP-OP overlap pattern specifically manifest on high-resolution CT slices, Dr. Giang?
We see ground glass opacities, parenchymal bands, and traction bronchiectasis at the lung bases, typical of NSIP, concurrently combined with patchy perilobular or subpleural consolidations, typical of OP. Occasionally, these consolidative areas form a classic atoll sign or reverse halo sign.
That sounds very impressive. What about myositis cases positive for anti-MDA5 autoantibodies? How does the HRCT appearance differ, Dr. Giang?
Anti-MDA5 antibody is a major red flag. Patients often present with amyopathic or clinically subtle myositis, yet their lung involvement progresses rapidly into a diffuse alveolar damage, DAD pattern. On HRCT, we observe bilateral diffuse ground glass opacities and consolidations that rapidly progress within days, carrying extremely high mortality.
How terrifying! So besides HRCT imaging, what extrapulmonary clinical signs and serological tests should guide us toward myositis and antisynthetase syndrome?
Clinically, look for mechanic's hands with hyperkeratotic fissured skin, Gottron papules over metacarpophalangeal joints, Raynaud phenomenon, and proximal muscle weakness. Serologically, check serum creatine kinase levels and order a myositis-specific antibody, MSA panel, including anti-Jo1, anti-PL7, anti-PL12, and anti-MDA5. Very clear, Dr. Giang. Turning now to Sjögren syndrome, what distinct HRCT patterns characterize interstitial lung involvement in this disease? Approximately 10% to 20% of Sjögren's patients develop interstitial lung disease. The most classic HRCT presentation is LIP, lymphocytic interstitial pneumonia. What is the most characteristic imaging finding of LIP on chest HRCT, Dr. Giang? It is the combination of ground glass opacities, poorly defined central lobular nodules measuring 2 to 4 millimeters, and notably thin-walled cysts. Cysts in LIP range from 1 to 30 millimeters in diameter, are distributed along bronchovascular bundles or in lower lobes, and occur in up to 80% of cases. By the way, Dr. Giang, in Sjögren syndrome, we also hear about cystic pulmonary amyloidosis. How do we distinguish cystic amyloidosis from pure LIP? In reality, pulmonary amyloidosis in Sjögren's often coexists with LIP. The key differences are that amyloid deposition produces parenchymal nodules or calcifications, marked interlobular septal thickening, and perivascular thin-walled cysts.
Parenchymal biopsy showing apple green birefringence under polarized light with Congo red staining remains the gold standard.
On the extrapulmonary clinical side, what symptoms do Sjögren's patients report, and which serological markers are definitive?
Patients present with the classic triad of keratoconjunctivitis sicca, dry eyes, xerostomia, dry mouth, and parotid gland enlargement. Serological testing reveals positive anti-Rho, SSA, and anti-LA, SSB autoantibodies.
Here is a very challenging question, Dr. Giang. Many radiologists still write rule out IPAF in their HRCT conclusion. Is IPAF actually a radiological diagnosis?
That is a very common cognitive trap. IPAF, interstitial pneumonia with autoimmune features, is absolutely not an imaging pattern or a radiological diagnosis. It is an international multidisciplinary consensus framework proposed by ERS and ATS in 2015 for patients with interstitial pneumonia and autoimmune features who do not meet full criteria for a defined connective tissue disease.
How is this ERS ATS 2015 IPAF criteria framework structured across domains, Dr. Giang?
The IPAF framework consists of 3 domains: clinical domain, serologic domain, and morphologic domain. A patient must fulfill criteria in at least 2 of these 3 domains to be classified as IPAF.
What specific parameters make up each domain in the 2015 IPAF criteria, Dr. Giang?
The clinical domain includes mechanics hands, digital tip ulceration, inflammatory arthritis, Gautran sign, and Raynaud phenomenon. The serologic domain requires ANA titer greater than or equal to 1 to 320, RF greater than or equal to 2 times the upper limit of normal, or positivity for anti-CCP, anti-Rho, anti-LA, anti-tRNA synthetase, or anti-MDA5.
What HRCT patterns are accepted under the morphologic domain, and why was the UIP pattern excluded, Dr. Giang?
The morphologic HRCT domain accepts NSIP, OP, NSIP-OP overlap, and LIP patterns. The UIP pattern was deliberately excluded from IPAF criteria because UIP lacks specificity for autoimmune etiology and is strongly linked to idiopathic pulmonary fibrosis, IPF.
That is such a valuable insight. Suppose we have a clinical case. A 48-year-old female with progressive dyspnea, mild dry eyes, and HRCT showing lower lobe ground glass opacities, traction bronchiectases, and 5 scattered perivascular thin-walled cysts. How would you approach this case?
We recognize on HRCT a combination of NSIP and LIP-like cysts. I would immediately request a multidisciplinary team, MDT, discussion, order a Schirmer test for dry eyes, measure ANA, anti-Rho, anti-LA, and run an MSA panel. Combining HRCT patterns, extrapulmonary symptoms, and serology leads to an accurate diagnosis of Sjögren syndrome, or IPAF.
Outstanding! Could you summarize 3 core takeaway messages for our colleagues from today's podcast episode, Dr. Giang?
First, an NSIP-OP overlap pattern on HRCT strongly points toward antisynthetase syndrome, while thin-walled cysts with ground glass opacities suggest LIP in Sjögren syndrome. Second, proactively examine for extrapulmonary signs like mechanics hands or dry eyes, and order autoimmune serology panels. Third, IPAF is not a radiological diagnosis, but an MDT, multidisciplinary framework between radiology, pulmonology, and rheumatology.
On behalf of VietRad Podcast and our listening doctors, thank you sincerely, Associate Professor Trường Giang, for these highly practical and deep clinical insights. Wishing all colleagues accurate diagnoses, and see you in the next episodes of VietRad Podcast.